Hi, Ashley.
Hi, good afternoon. All right, so you're going to join me for some questions from the waiting room.
I love it. I love me some questions from the waiting room.
All right, so these are some questions folks have written in, things that they wish that they could ask their provider, but they've never had a chance or they've never had the courage.
Okay. Yep.
One is, I'm trying to start any beef with anyone. Why should someone see a psychiatrist instead of just their PCP for medicine?
Well, it's interesting because primary care doctors probably do the most prescribing of all psychotropics. So psychotropics like an antidepressant or maybe a mood stabilizer. So they actually do the heavy lifting of all mental health in probably North America. But when they would see a psychiatrist, like someone like myself or Dr. Rahman here or Dr. Anson, would be when they're not getting better, or if the primary care doctor is at the end of their knowledge about what to do and they feel like it's out of the scope of their practice. So that would look like maybe they start a medication for anxiety like Lexapro. They wait to see if it works, then that doesn't work, and then they start something else maybe. Sometimes there can be side effects, so that's the reason why they changed. Here, what we do though, we do a deeper dive with folks. Instead of meeting them maybe for a shorter amount of time that a primary care doctor might have, we will meet with them for at least 90 minutes to really zero in on all the nooks and crannies of their mental health. That's a lot of the work that you do, right, at the or front desk, where you're gathering a lot of rating scales and their weight, their blood pressure. We ask like what their past medication responses have been or a list of past meds that they've taken. So I have a lot of information when they just sit down with me. And then we go through with a fine-tooth comb for the proper diagnosis, because sometimes it's really hard to diagnose, like, for example, bipolar disorder. And a primary care doctor might say, hey, that's a little bit out of my league. However, there's plenty of primary care doctors who really like working with folks having mental health issues, and they have more training. They've done a lot more self-study than not, and so they might feel comfortable taking care of someone with bipolar disorder. And where we'd see that maybe would be like in a rural community where the family doctor or like an OB-GYN would be the only doctor for miles. So they may have to do a whole variety of psychiatry, practice psychiatry. Here also, I do a lot of second, third, or fourth opinions for people who've seen multiple different providers and they're not getting better. Sometimes we call that treatment resistance, so treatment-resistant depression. We also offer transcranial magnetic stimulation here, which is a whole nother type of treatment that only a few not a lot of psychiatrists provide that. Not every clinic has that. Or we do Spravato or ketamine treatment. That's the treatment for depression. Or we do genetic testing. Or patients want to know, like, hey, what type of therapist do I see? And I have a whole host of tools at my disposal here, in that we have different types of therapy treatments. So if somebody had trauma, they shouldn't be doing maybe your typical supportive therapy. They should probably meet with somebody who knows a lot about trauma therapy or EMDR, for example. And we do that all together. And usually a doctor should have a network of other people that they work with, either in the community or under the same roof, trying to achieve the mission of getting someone well. Too much? I answered too much there.
All right, now I have another question for you.
All right, bring it on.
This one comes from Trey. Says, what is your favorite self-help book? If someone needed
it's a good
real
question.
quick good advice, what do you recommend?
Scott Peck, I believe, has one. I think it's called On Love. No. The Road Less Traveled and Beyond. I think it's the name of it. And it has a chapter on love, about like loving people in relationships, which I really thought was helpful, especially when I was in my dating period. And before I met my wife, when you're going to settle down with someone, you really want to get it right and do your part well in the relationship. So I thought that was really helpful. aside from that, I always felt that the 7 habits of highly effective people, I know like I probably talk about way too much with patients here, but I have folks where they just don't, they haven't zeroed in on what their own personal mission statement is, kind of like a company would have a mission statement. So this book talks about one's own mission statement and organizing your life around like principle-based thinking. Some people have lives that are organized around religion, where they have to go to church every Sunday, which is fine. I'm for the supportive nature of church and spirituality, but say someone had their tire on the side of the road go flat and needed help, and they were a friend of a person. There's some folks that might opt to just go to church and not help the friend out. I know it's an extreme example, but it's extreme for a reason, to show like where that person might be organized around. Or, you got these folks who run hedge funds in New York City, and it's all about flash and money and materialism. And so their lives might be organized around that. Or another example would be like being organized around one's family. I have a lot of patients where they'll do anything for their family at the cost to themselves, and that creates unhappiness. And they don't know how to tell mom or dad or brother or sister no. And so this book kind of talks about like just organizing your life based on principles, like having integrity to yourself, or being trustworthy, or being honest with people. And being honest in those things can be really hard, and so it talks a lot about that. And then what I really like about that book is it talks about what is it? There's like 4 quadrants of time management, and it teaches folks to live within a quadrant that is doing things that are not urgent, but are indeed important. The main example of that is exercising. So a lot of people won't exercise because there's always something more urgent to do, but it's very important. So you can imagine all the other things, like maybe writing a thank you note is important, but never urgent. You know what I mean? And so I always found that helpful to kind of organize my time, and I'll recommend it to patients who are having kind of time management issues and just need to get their inner game on point. So that's probably what those are.
All right, those are 2 good recommendations.
I'm probably dating myself because some of these books are like written 30 plus years ago. But I guess I don't know. I'm getting old here, Ashley.
All right, well, I'm going to throw you something a little newer. It's
Okay.
very popular to talk about right now. What is an attachment style, and can you change it if you don't like the one that you have?
Wow, that's a good one. Yeah, so attachment styles are how somebody attaches to their a significant figure in their life. Some children coming out of their adolescence and stuff, they may have had a parent that was praising them, where another one was like devaluing them, or one showed up for them and one didn't. So it kind of gives them a confusing sense of their attachment figures, which are supposed to be your parents at first. And then you generalize that to other people when you move on. So some people have an anxious avoidant type of attachment, where they ideally want to be in a relationship, but they're too anxious to engage, or when they feel like they're getting close, they'll back away because they're used to being disappointed by their parental attachment figure. So they have to work through that. And in therapy, what they can do is talk to the therapist about it, and the therapist can kind of reparent them in a way where they can be consistent with them and show up for them, so to speak, and help them understand this dynamic within them, and maybe be encouraging of trusting people a bit more. And when people don't show up for them, like we all have friends, and I'm sure I've been the friend where they say they're going to do something, they don't show up to go play basketball with me or go out to dinner when we said we're going to do it. And people are busy and stuff happens. But if you have an anxious avoidant attachment, you might sense that as like the friend hates you, or you might imagine that it's like, well, this is what happens to me in my life, and I can't trust people. When really the person may have just had a bad day at work or had a migraine or something. You know what I mean?
Mm-hmm.
So I think it could definitely be worked upon and improved. Definitely in therapy, a longer lasting relationship with a therapist can really help that out.
So what kind of therapy would you recommend for that? You said reparenting?
Well, I'm borrowing that phrase. I don't think we'd call it reparenting, but in a sense, if you have a therapist that's older, that you might project some of this onto the person. A lot of it's unconscious projection. Like the patient's not aware that they're doing it sometimes, but the therapist knows that that might be recreated in the relationship. Where this, and I'll answer it more directly in a second. A lot of times, if a patient is feeling ambivalent about the therapist-patient relationship, they might test the therapist by being late for appointments or not showing up. So imagine if you're someone who has anxious avoidant attachment and you don't show up for an appointment because you're getting too close to the therapist emotionally. They might unconsciously be thinking, "Will the therapist call me?" Whereas my father, who didn't show up for my Little League games and was inconsistent, will this therapist actually call me when I miss an appointment? Something like that. So as to the type of the therapy, actually I don't know 100% off the top of my head. What comes to mind though is doing schema therapy. Schema therapy is where you explore one's identity and what they call schema. It's based on Carl Jung's research and therapeutic technique from way back when. And here at our clinic, Danielle Zalisco practices that type of therapy. And then if you do cognitive behavioral therapy and you get into like somebody's core beliefs about themselves, sometimes that gives rise to the type of dialogue that they're having with themselves, and you can correct that internal core belief and help them have a more reasonable belief system that helps them forge relationships and longer relationships. And there's also psychoanalysis too. We call that psychodynamic psychotherapy. That sometimes can address attachment issues as well. But yeah, that's the way I think about it.
So I got another one for you.
Okay.
I requested my chart from my psychiatrist and they denied me having it. Why would they do that?
Well, that's not allowed. Now, it depends on what type of chart it is. Only in that, if it's a therapist, sometimes therapists have written notes, general notes about a case that they keep at the office locked away, but they may not have identifying patient information on it. Mm-hmm. It's not part of their electronic medical record per se. But usually, by law, if somebody requests their records, we have to give them their records. And I don't know if that's like a newer or older question that was submitted, but I think over like a year or two ago, there was a law that was enacted that mandated that patients have access to their records. We have electronic medical records now, and it's in the patient's best interest to be able to, that they have them, or we can send them to a hospital if the patient's hospitalized, or vice versa. If we're all using a similar system, it's easier to get information. It's better for the patient's health overall. Where this is a problem, and why the psychiatrist may have not have wanted to give the records, is if there's documenting something in the records that they thought would be harmful for the patient. And usually that's like in a therapeutic dynamic. So I see patients mainly for medication management or business coaching, also to create a treatment plan and to enact a treatment plan to do transcranial magnetic stimulation and like ketamine therapy and genetic testing. So I'm just doing the technical part of that. And in the chart, and most doctors should chart favorably, where if someone's not taking a medication, I don't say they're not compliant to their medication. I might say the person stopped taking Lexapro because they had libido side effects and decided to taper off before seeing me. You know what I mean? So it's not like a disparaging thing. Back in the old days, doctors might have been charted less friendly, And if a patient saw that, they might be affected by that or offended by it. Now, if you're doing therapy with a psychiatrist, some psychiatrists do therapy. If they're documenting a lot about the nooks and crannies of the person's private life there, and the doctor is opining, giving opinion within that chart, then they may not want the patient to have exposure to all of that. And they might find that it affects the therapeutic relationship. However, those days are gone where you have to, whatever's in the chart, the patient should have access to so that they can make decisions about their health care, so that they know what medications they're taking, what dosages, or whatever they need it for. Sometimes they need it legal, sometimes they need it for school. There are occasions when somebody might want their whole record, but all they need is a letter from us summarizing what their diagnosis is and the treatment plan. And they don't need all the 120 pages to the record, and it's for school or something. So we might offer that if that's what they actually need.
Okay.
But yeah, they should get their records.
Okay, good. And then if someone requests their records for them, another doctor or a school, do you have to give the entire record, or can you choose what to give them?
Yeah, so that's a really good question. If the patient wants their record, I'll warn them and say, take your record, fine, but you may not want all this information, your school to have it. You might want to get a limited release to the school so they just have what they need. For example, if one of my patients did a medical withdrawal from college and they're now coming back to school, I might just say, hey, let me write a letter or show them only your one diagnosis of depression, but you don't need to tell them about past traumatic abuse from when you were a kid or all the nuance to their case. That way the school is satisfied because they go, okay, this is a student had depression, they got into treatment, they took some medication, they did therapy, they got better. And they don't need to know all the details, which are probably more private, that the patient may not want their school to have. So it's more us looking out for the patient that we might do that.
Good information.
Yeah, absolutely. Those are really good questions. Very good questions.
So if I got one more for you. All right. I looked up a medication that my doctor prescribed me, and it says it's an antipsychotic. I am not psychotic. Why would I have this medication?
That's a really good question. So antipsychotics are indicated for folks who are having psychosis, which is when patients are having delusions, like they're very paranoid, or they're having auditory hallucinations, like they're hearing voices that other people can't hear, which is highly distressing, or they are having visual hallucinations, which can convey psychosis. It also can convey delirium, which is a different diagnosis. So a lot of the medications in psychiatry were first indicated for psychosis. Folks with schizophrenia, schizophrenia is synonymous with psychosis, right? In a medication or a pharmaceutical company, they will put a lot of research and development into making a medication that treats psychosis. And in that business, they need to have one indication at first to get into the marketplace. And they have to test the medication, which they call medication trials, to prove that it actually works. And that takes lots of money and time to do. Once that medication is in the marketplace, the company will often try to find another reason to prescribe it, where they will then label it for bipolar disorder or major depression. And then how that works is that the antipsychotic pushes a few different buttons in our brains, and some of those buttons help with schizophrenia, some of those buttons help with mood stabilization for bipolar disorder, and some of those buttons help with depression, like unipolar major depression. So when I prescribe it to a patient, let's say it's Seroquel or Vraylar, those are often indicated for schizophrenia, but they can also be used for treatment-resistant depression or bipolar depression. And then sometimes we use it off-label where it's not formally labeled by a drug company and the FDA for that reason, but chemically, pharmaceutically, we know that it very well might work, or anecdotally, we know it works, and it's relatively safe to try out. So when you give that patient that medication, they look it up, just as you said, they'll be confused unless their doctor really walks them through the informed consent procedure. And I think one day they may need to recategorize some of these medications to avoid that confusion for patients. And if and when and how that would happen, I don't know exactly. But that's all through like psychological education, or what we call psychoeducation, which is a lot of what I do here when I talk about medications with patients. Yeah.
Good answer.
Yes, good one. Questions from the waiting room. I love it.
I think that closes us out for today. More
Well,
for next time.
I'll see you next week.
All right. Thank you.
Okay. Thank you.